Welcome back to Simply Women's Health with CJ. Today we're going to talk about high blood pressure or hypertension in pregnancy. Hypertension in pregnancy is actually a really big deal. It can have devastating effects on both mom as well as baby. For the mom, we're talking possible liver, kidney dysfunction. You could have, in very rare instances, brain damage. For the baby, hypertension, uncontrolled hypertension, can lead to preterm birth. It can cause harm to the placenta and cause the baby to not grow properly. This is the reason that we really recommend that you have consistent prenatal care throughout your pregnancy, so we can keep an eye on your blood pressure. So when you first come in to have your initial OB appointment, in all likelihood, your provider is going to want to get a good, thorough history. Have you ever been diagnosed with high blood pressure before? Whether you're on medication or not is irrelevant. Has anybody in your family ever been diagnosed, mom or sister, been diagnosed with preeclampsia? Have you had high blood pressure in previous pregnancies? There's a number of different things that they need to look at. They need to look at your past medical history. They need to look at your BMI. There's a bunch of different things that your provider is going to want to evaluate. And they're going to decide whether or not you're at increased risk for developing high blood pressure later in pregnancy. If your provider determines that you are at risk, they're probably going to want to order some baseline labs just to know what your lab work looked like at the beginning of pregnancy. Your provider may also want to start you on a low dose or a baby aspirin right around 12 weeks. For my clinician followers, I have actually attached the most recent set of ACOG guidelines regarding aspirin use in pregnancy. So basically, there's 4 different kinds of high blood pressure in pregnancy. The first one is chronic hypertension or pre-existing hypertension. Chronic hypertension is hypertension that was diagnosed prior to conception of your pregnancy. You can also be diagnosed with chronic hypertension if you have an elevated blood pressure. And an elevated blood pressure is anything, the top number or systolic number at or above 140 and or the diastolic or bottom number at or above 90. You have to have 2 elevated pressures, and the blood pressures need to be a minimum of 6 hours apart to make a diagnosis of hypertension. So if you come in and you're in the first half of your pregnancy and you have elevated blood pressures, your provider is probably going to want to order a little bit of lab work, and they are probably going to want to have you come back within a few days to recheck that blood pressure to see if you are in fact chronically hypertensive. The second one is preeclampsia versus gestational hypertension. Those occur anytime after 20 weeks. If you come in and you have elevated blood pressures after 20 weeks gestation, again, your provider is going to want to order some lab work, and they're going to want to have you come in for a repeat blood pressure check. Within the lab work, they want to check liver function, and they want to check kidney function and make sure you're not spilling any protein into your urine. If you have an elevated blood pressure times 1 and your lab work is completely normal, you're not diagnosed with hypertension at that point because, again, you don't have 2 abnormal blood pressures. Now, in my practice, I will typically put a note in your chart that you had an isolated blood pressure at whatever gestation you were, and then if you have another one later in pregnancy, now you have tested in for hypertension because you have 2 elevated blood pressures. If you have 2 elevated blood pressures and your lab work is normal, you have gestational hypertension. If you have 2 elevated blood pressures and your lab work is abnormal, you are spilling protein, your liver function tests come back looking a little bit wonky, you test in for what's called preeclampsia. The 4th blood pressure is what's called chronic hypertension with superimposed preeclampsia. That's a mouthful. Those are patients who already had pre-existing hypertension who in the second half of pregnancy start spilling protein in their urine. So now they have chronic hypertension, but they also have preeclampsia. So As I tell my patients all the time, especially in that last part of pregnancy, you are not monitoring your blood pressure all day, every day, and these things can come on pretty quickly. 15% of patients will have elevated blood pressures. 4% of those patients will have preeclampsia. What causes preeclampsia? We are not sure, but we do know that it is a placental dysfunction. So the warning signs that I will give my patients, especially in that last trimester, severe headaches. Won't go away no matter what you do. Changes in your vision, black spots, flashing lights, tunnel vision, primarily at rest. A lot of times in pregnancy, you can bend over and get back up and get shooting stars that will resolve in a few minutes, and that's perfectly normal. Those are normal pressure changes in your head. I'm talking about visual changes primarily at rest. Burning behind your right breast or epigastric pain. I always explain to my patients it's very normal to have heartburn here where your esophagus is, but you shouldn't have heartburn in your liver. If you are diagnosed with either gestational hypertension or preeclampsia, or even the last one, superimposed preeclampsia, you are going to be monitored a little bit more closely. They're going to want to do growth scans. Remember, high blood pressure can be very hard on the placenta, and it can cause the placenta to stop functioning, and so the baby may not grow appropriately. They are going to want to do what are called non-stress tests. They're going to bring you in, put you on the monitor, and watch you for anywhere from 20 to 40 minutes, depending on how your baby is behaving. Again, making sure that that placenta is working okay. And depending on what your lab work shows and depending on how you and the baby are doing, they're probably going to want to talk about inducing labor before you get to your due date. They're also going to be keeping a close eye on your blood pressures and on your lab work. If your blood pressure suddenly skyrockets and goes up to anything at or greater than 160 and or at or greater than 110 diastolic, that is what's called severe preeclampsia or preeclampsia with severe features. Those patients will often have horrible headaches. They will often have profound visual changes, again, bad epigastric pain. This is actually a very serious condition, and generally we want to get the patient delivered as quickly as possible because, again, those are the cure to all of this is getting the placenta out. In very rare cases, if a patient develops severe preeclampsia, they can go into what's called HELP syndrome. HELP stands for hemolysis, elevated liver, low platelets. So the elevated liver, again, that's where liver damage comes from. Low platelets, these patients can start bleeding really heavily and have developed even what's called VIC because of the profound drop in their platelet count. Thankfully, HELP is very rare, and even more rare than that is a condition called eclampsia. Eclampsia is elevated blood pressures accompanied by seizures with no other known cause for the seizures. Again, if your patient has HELP or has eclampsia, the key to that, the cure to that is to get the baby delivered. So what does this mean for your future? If you are a patient who has had gestational hypertension, typically those blood pressures go away not long after birth, usually by about the second week they go away. If you still have elevated blood pressures after 12 weeks, then it's probably more chronic hypertension and not gestationally related. If you have been diagnosed with preeclampsia and it has been mild, manageable, elevated blood pressures, but you didn't require delivery before 30 weeks, the good news is you really only have a 5% chance of it recurring with subsequent pregnancies. If you do have preeclampsia with your next pregnancy, your provider is going to definitely want to get some baseline lab work, and they're definitely going to want you to take a low dose or a baby aspirin throughout the next pregnancy. If you have severe preeclampsia and you had to be delivered before 30 weeks gestation, Unfortunately, those patients have a 70% chance of it occurring again. So that is something, again, if you had bad preeclampsia, your provider is definitely going to want to have get the details on that. So women who have preeclampsia and gestational hypertension, studies have shown that they are at increased risk to develop cardiovascular disease later in life. So it is really important for those patients to follow a good, healthy diet, exercise on a regular basis, and try to maintain a relatively low stress existence. Hi, if you're still here, thanks so much for sticking around through the entire video. If you feel as though this information has been helpful to you, or you think you know somebody that might benefit from the information provided in these videos, please feel free to like it, share it, and if you haven't already subscribed, I would love it if you did that. Any and all support that you can provide is so greatly appreciated. As always, these videos were not created as a replacement for a visit with your healthcare provider, rather as a place for you to come for basic, reliable information that is non-biased and hopefully allow you to figure out what questions to ask your healthcare provider at your next visit to best meet your healthcare needs. Again, I appreciate all of your support. If you want to contact me, my information is at the top of this screen, and I will put it in the comment section of this video. That's all I have for today. This is CJ. I'm at your cervix.